Good evening, everyone, and thank you for attending AACP's webinar with Dr. James McKee and Dr. Thomas Predey, presenting MRI of the TM joint. I'm Shaylin, the Association Manager for the AACP, and I will be the host of the webinar tonight. This webinar is approximately 50 minutes, followed by a 10-minute Q&A session. Please enter any questions you have in the Q&A box at the bottom of your Zoom screen, and we will address them at the end of the presentation. Dr. McKee and Dr. Predey have no conflicts of interest. Registrants can expect to receive a recording of this presentation via email within 5 to 7 business days, and AACP members attending live will receive their CE certificate of attendance within 30 days of the webinar air date. I would also like to mention a couple of upcoming events for the AACP. Our next complimentary webinar will be April 12th with Dr. Bahar Ismaili on mysteries of the mandible from nose to toes. Also, for education, camaraderie, and the latest in craniofacial pain, please be sure to visit aacfp.org to register for this year's annual symposium in San Antonio, Texas, August 11th and 12th. The mornings are filled with deep dive education, and the afternoons are packed with hands-on learning workshops. We also invite you to join us a day early for the pre-conference workshop on August 10th. I would like to introduce our speakers tonight, Dr. James McKee and Dr. Thomas Predey. Dr. James McKee is in private practice in Downers Grove, Illinois. His practice is restoratively based with an emphasis on occlusion and temporomandibular joint disorders. In addition to his practice, Dr. McKee is a published author who has lectured nationally and internationally for over 25 years. He is a resident faculty member at Spear Education in Scottsdale, Arizona. Dr. McKee is also a past president of the American Academy of Restorative Dentistry and the American Equilibration Society. Dr. Thomas Predey is a diagnostic radiology specialist in Schaumburg, Illinois. Dr. Predey graduated from Loyola University of Chicago. He has written several published articles and is a member of many professional societies, including the American Society of Neuroradiology, American Society of Spine Radiology, and the American Heart Association Council of Cardiovascular Radiology. He currently practices at Open Advanced MRI of Schaumburg LLC, specializing in diagnostic radiology and nuclear medicine. And with that, it is my pleasure to turn it over to Dr. McKee and Dr. Predey.
I know on behalf of Tom and myself, we'd like to thank the Academy for this opportunity to do this webinar. You know, I've been associated with AACP for many years. I know a lot of AACP members. So I'm really looking forward to sharing the information that Tom and I have been working together really for over 25 years now. Tell you what, we have a lot of material to get through. So what I'm going to do is I'm going to get started. And what we're going to do, we're going to answer 4 questions in this webinar tonight. Number 1, why do we image joints? Number 2, when should we consider imaging joints? Number 3, how do we image joints? And number 4, what do we learn from joint imaging? So let's start out with the why. The why is the same reason we image people who come in with decay, because ultimately we're trying to see how much tissue damage has occurred, because we're trying to assess the treatment planning risk factors. It's the same in the jaw joint. We're used to dental imaging to be able to assess anatomic changes that influence our discussion with patients. It's the exact same thing at the jaw joint level. Ultimately, treatment planning risk factors are going to increase with structural alterations in the joint. So let's start out with what normal joint anatomy is before we talk about abnormal joints. Now, I know this is an MRI webinar, but I'm going to show you a lot of CBCTs too tonight. And the reason is, as Tom and I have found out over the years, if you don't have both, you're really guessing at one or more parts of the system. Generally, CBCTs are going to emphasize hard tissue, and MRIs are going to emphasize soft tissue. If we don't have both of those, I'm guessing at one of them. So we're going to talk a lot about MRIs, but I do want to have CBCTs in here because that ties the whole picture together. CBCT coronal view, lateral and medial orientation, condyle in red, joint socket in yellow. Here's the MRI, same corresponding view. The difference is we've got a disc in here because CBCT doesn't pick up soft tissue. So if we don't have the MRI, the best we can do is to look at the joint space and see if we could draw a normal joint space, a disc in that joint space. Here's the side view or the sagittal view of the CBCT. And then from there, anterior posterior orientation, condyle in red, joint socket in yellow. The slide on the right is the more traditional slide that we're used to seeing. And what that is, that's the MRI, that anterior posterior orientation. And we've got the disc outlined in blue. So now that we know what normal is, I want to talk about a few points before we move, though, to structurally altered. First thing I want to point you out to is the bone at the medial pole. If you take a look at the bone at in a coronal view at the medial aspect, that's perfect for load distribution. We know the medial pole is a load-bearing portion of the joint. What we want to start thinking is about if we don't have a soft tissue protection for that, it's going to increase the likelihood that we may have pain upon loading. Very simple concept, easy to think about. Okay, so the second thing, that soft tissue disc fills a space, and what that does, it helps position the condyle. We talk about vertical dimension at the tooth level. We're going to look at cases tonight where we lose maybe 10, 12, 15 millimeters of vertical dimension, or we never gain it to begin with. And when we talk about vertical dimension at the tooth level, it's 2 to 3 millimeters. So the real vertical dimension changes that we have to be worried about, especially as a restorative dentist or a specialist, maybe an orthodontist, is going to be vertical dimension at the joint level because it dwarfs the loss that we're going to see at the tooth level. Now, if we don't have a disc at the medial pole, because that's what maintains the vertical dimension, it's going to increase the likelihood that we're going to have a mandibular change in position, and it's going to influence the chance we're going to have a malocclusion. Okay? The other thing I want to talk about is that the disc is going to foster normal growth of the mandible. That's the part we're used to hearing about is the mandible. What I'm going to tell you tonight also is that the maxilla is influenced by disc displacements as well. And if there's a disc displacement in the right joint, there's a higher likelihood that the right maxillary area isn't going to grow as well either. So don't think joints are simply related to the mandible. Now, ultimately, again, the loss of dimension of the disc at the medial pole is going to increase for malocclusion. So let's start out by looking at normal soft tissue disc position, disc condition. The 11 o'clock position is the load-bearing part of the joint, which is going to put the posterior band at about 1 o'clock. There's a lot of confusion in the literature about this, and I just want to touch on it to clear that up. You're going to hear a lot of times the disc is supposed to be at 12 o'clock. If you look at the literature and really read it carefully, Grace talked about in 1990, 12 o'clock plus or minus 10 degrees. Ramelsberg in 1997 talked about 12 o'clock plus or minus 30 degrees. And when you have that big a variance, what you know is you don't know what normal is. Provenzano really brought a lot of clarity to the discussion about disc position in 2012, because he said the disc should be analyzed from where the load-bearing potential of the disc is. The bow tie, the thin part of the bow tie is going to be about 11 o'clock, which is going to put the posterior band closer to the 1 o'clock position. The 12 o'clock plus or minus the 10 degrees position that Drace talked about. So it makes sense because you'd like to have that soft tissue wrap the back of the condyle and protect it during movements. Now, the disc is positioned and held in place by ligaments at the lateral pole and the medial pole. So that's the key aspect, and really the first domino that's going to fall in any type of joint case typically is a soft tissue ligament injury. I believe today, as Alamar said in 2007, that the disc is really the most important tissue in the joint because it fosters normal growth, it provides load distribution, it provides a repeatable condylar position. We're going to talk about this. Think of that disc as a soft tissue gasket that positions the condyle three-dimensionally. So now when we close, that pathway of closure is going to be the same each time. So it really allows us to build an occlusion that can be very stable. Now, let's go the other way. If the disc isn't there, the likelihood that we're going to have the patient that can't quite get the bite right, that comes back for repeated adjustments because it doesn't feel like they're balanced and hitting evenly, a lot of times that's because the disc isn't there. We've got nothing to stabilize the back end of the system. So that's the soft tissue discussion. The hard tissue discussion is normal bone growth should lead to a condyle that fits about 2/3 of the joint socket. 8 millimeters anterior to posterior is normal growth, 20 millimeters lateral to medial. Those are approximate numbers, pretty close. Orthopedically, we want this centered in the joint socket like any other orthopedic joint. We want to have a normal marrow space, and we want to have a cortical plate that's intact. So that's what we're looking at from a hard tissue perspective. If we have that, all of a sudden now we get some really stable results in terms of our occlusion and restorative dentistry. So when we put it all together, the joint vertical dimension is made up of the soft tissue of the disc and the hard tissue of the ramus. Hard tissue of the ramus length is, let's call it between 60 and 75. 60 on the smaller end, 75, you've got a really big person. But it's made up of soft tissue disc and hard tissue bone. And you can have normal vertical dimension. We can have increased vertical dimension, which is fairly rare. We can have decreased vertical dimension, which is common. But I think when we talk about decreased vertical dimension, we're always thinking about a joint degenerating. I'm going to suggest we think about it the other way. We hear a lot in the airway world that young kids have airway problems. I'm going to tell you, young kids have joint problems too. And if the disc comes off during the growing years, the likelihood is that that bone isn't going to grow either completely or normally. So a lot of the early malocclusions that we see in the orthodontic world that now lead into the airway patients, as airway world as patients get older, can be very easily explained by understanding vertical dimension at the joint level. So if we look at normal anatomy, I'm going to play a video here so you can just get an idea. I know you've probably seen these videos, but I want you to look at it from a different perspective. I want you to take a look at a couple of things. I want you to take a look at the space between the top of the condyle and the top of the joint socket. And I want you to take a look at the angle in terms of how the condyle is functioning. This is a normal joint. You can see it on the video. You can see it on the MRIs. The disc gets its nutrition from synovial fluid. So if the disc doesn't get nutrition, because now in a clicking joint, what happens is the disc isn't in the right place. The disc is clicking because the ligaments are torn, and now it's not in the correct position to get synovial fluid compression. Look how much smaller the disc is in the video than the first disc. And look at the decrease in the vertical dimension at the joint level when you take a look from the top of the condyle to the top of the joint socket. You're going to have a decrease in vertical dimension at the joint level. What's that going to do to your occlusion? A decrease in dimension at the joint level generally leads to a class 2 bite shift. That's honestly why there's so many class 2s out there, because they're really joint-based cases that have simply seated in joint socket, and now you start to see the defect at the bite end. The click is opening on to the disc, and the closing click is popping off the disc, as you can see in the video. Now, we have potential increased risks, because not all clicking joints are a problem. Not all clicking joints can be treated, and quite frankly, not all of them, we don't have great treatment options for them anyway. But our potential risk factors is number one, force distribution that something hurts, or a malocclusion that something doesn't fit. And that can be at the tooth level. It also could be at the pharyngeal airway level. We're going to look at some airway cases tonight that have some joint-based considerations. And by the end of the webinar, I want you to start thinking a little bit differently about airway in terms of relationship to the TM joints. From a clicking joint, it goes to a locking joint. That's where the disc doesn't get back on top of the bone at all. You can see it in the MRI, and now you can see it in the video. Basically, now we're starting to see a little bit more bone wear against that eminence. You see how it's getting flatter there? What that's going to lead to is the back teeth dragging now and horizontal movements of the mandible. There's going to be history of a previous click in this patient. Basically, the disc has changed shape, so it can't get back underneath the bone. The potential risk, again, potential, force distribution issue and malocclusion issue. Something hurts, something doesn't fit. It's the easiest way to explain it to our patients. If you have a jaw joint problems, Mrs. Jones, the easiest way to think about it is something hurts or something doesn't fit. We might want to take a look at this with some imaging, just like you would for a shoulder and knee, and get an idea of what we'd be looking at so we can understand why we're seeing the things we're seeing. Easy way to introduce imaging to patients. The last joint stage is perforated, where it's bone to bone now. And again, I'm going to ask you to do a little game here. Take a pencil out in your mind's eye, and I want you to draw the rest of that condyle, and then I want you to draw the disc in. How many millimeters of vertical dimension have been lost in this case? I'm going to tell you it's probably at least 8 to 10 millimeters of bone, another couple millimeters of soft tissue. You're probably 10, 12, 14 millimeters at least of vertical dimension. What's that going to do to the bite? That's going to be a huge class 2 bite shift. The greater the bone change, the more likely the class 2 bite shift. We always make this about pain, but this can be painful or these can be adapted. So start thinking about it in terms of the bite, in terms of the jaw joint, instead of pain. Potential risk factors, again, something hurts, something doesn't fit. So that's why we image joints. Question is, when should we consider imaging jaw joints? It basically depends upon the joint condition. We talk about normal joints. We talk about disc displacements with reduction. We talk about disc displacements without reduction. And we talk about perforated joints. That's generally how we discuss joints. But none of those assess disc coverage at the medial pole. So none of them are really talking about the risk factors in treatment planning. If the disc doesn't cover the medial pole, risk factors increase relative to pain and relative to bite changes. Something hurts, something doesn't fit. So we want to be able to assess the joint condition at the medial pole to really understand the restorative risk factors during treatment planning. Let's look from a top view. So we've got structurally intact joints where the disc is attached at the lateral pole and medial pole. I've outlined the discs in blue so you can kind of get an idea. This is actually how I explain it to patients. I think it's the easiest way to understand it. We've got structurally altered at the lateral pole, where now we've got a ligament tear at the outside. The disc is still attached on the inside, though. So the load-bearing part is still covered. We still have maintenance of vertical dimension, so we probably don't have a bite change. When I said potential issues, if the click is limited to the lateral pole, we're probably going to be okay. That's the 60-year-old guy who's clicked in your practice for 35 years and never had a problem. Now, different case. The structure altered at the lateral pole and medial pole, disc is off at the lateral, disc is off at the medial. So, completely different case. Now we don't have load coverage, or we don't have disc coverage during load distribution. We don't have the soft tissue with a gasket maintaining condylar position, so a higher chance for bite changes. But when we start to risk profile these, normal joints are green. We can pretty much do anything we want. If we can get the teeth to fit, we're going to have a very stable case, whether it's restoratively, whether it's orthodontically. We're going to generally have occlusions that are going to last a long time and really protect the teeth. If we have the disc off at the lateral pole, there is a little bit more risk, but we're still pretty good here because we have the load-bearing part being protected and we've got the bite mean being maintained as well. Now, when we get over to the structurally altered at the lateral pole and medial pole cases, we're going to increase our risk here. Now, to be fair, we have yellow cases in this category, and I want you to be really clear that you're going to do a lot of dentistry on these types of patients. They're going to have structurally altered joints, but adapted. But here's the part I also want you to understand. They all don't adapt. You know, when you go to a lecture and you hear people say, oh, they did 12 weeks of splint therapy, everyone adapted. No, they don't. A lot of them do, but not everyone adapts. So we need to be really clear that generally, the reason they don't adapt is because they have more anatomic structural changes, more anatomic tissue damage than other cases. And that's really what imaging allows us to do, is to really try to pick up who are the red cases, because those are the ones we want to be able to pick up. Because if we miss those and we're thinking that the joint is relatively normal, those are the cases that become more difficult to manage. We have normal soft tissue and hard tissue in our green cases. We've got partially herniated soft tissue because the disc is attached on the medial, and we don't know about the bone. We know the bone at the medial pole is probably fine. Lateral pole just depends how much load has been applied to that, if you've seen changes. And now in the yellow-red cases, we have a completely herniated disc, so there's no disc coverage, and we don't know about the bone. I want to be clear about this again. These yellow-red cases can be stable joints, and you don't always have bone changes. But if you do have bone changes, it's generally in this category. So again, these are the more risky cases for bone in terms of eroded bone, in terms of swelling in the marrow space, in terms of incomplete bone growth. Those are the things we're thinking about in these yellow-red cases. Now, Mark Piper developed a classification system that's been really easy to use as a restorative dentist when communicating this with colleagues that you're working with. The Piper stage 1 and 2 is a normal joint. Piper 1's completely normal. Piper 2 is just beginning lateral pole laxity, periodic clicks, no bite changes, no pain. A Piper 3A and 3B are the lateral pole clicks and locks. A 3A is a lateral pole click, a 3B is a lateral pole lock. Another way to say that is it's a disc displacement with reduction at the lateral pole for a 3A, and a disc displacement without reduction at the lateral pole in a 3B. Piper 4A, 4B, 5A, and 5B are the yellow-red cases. If 3A was a lateral pole click, 4A is a medial pole click. If 3B was a lateral pole lock, 4B is a medial pole lock. 5s are perforated. A is acute, B is chronic. Real easy way to be able to clearly talk about this with other dentists that you're working on this with. So it gives you an idea. Again, risk factors is basically what this tells me. The 1 to 3Bs are lower risks, again, because the anatomy is not that damaged. It's lower risk for the patients, lower risk for the dentist, lower risk for pain. These generally don't hurt. We don't have bite changes, and we have a decreased risk for compressed pharyngeal airway anatomy. So these are the cases. We don't have to image these patients. A lot of people say, do you image everyone in your practice? You can't image everyone in your practice. You have to have a way to figure out which ones you do need to image, though. And when I see cases that are 1 to 3B, we don't need to image those cases. We can just treat those as we normally would, assuming the joints are stable. On the other hand, the 4As to 5Bs are the ones we want to recognize because those are the higher risk for patients. You know, I've seen patients spend a lot of money and a lot of time on treatment that had no chance of working because the joints weren't imaged. So we need to do a better job decreasing the risk for our patients. Same thing for dentists. These are the cases that make dentists nervous. These are the hard cases, more pain, more bite changes. And again, if we're not growing well, which happens in a lot of these cases, we have an increased risk for compressed pharyngeal airway anatomy. These are the ones we're going to want to image. And we're going to use an MRI and a CBC too, because we want to see the soft tissue as well as the hard tissue. So what do I tell the patients if they've got clicks and joints? If it's a ligament tear at the lateral pole, it's a low risk factor. We're going to assume that you're stable until you prove us otherwise. If it's a medial pole ligament tear, we're going to have higher risk factors. Why is medial higher than lateral? Increased risk for pain with force distribution. We talked about medial pole is the load-bearing part. Normal disc position helps decrease excessive loading forces on the bone. If the disc isn't in the right place, increased risk for pain during force distribution. Think about this joint being loaded now with eroded bone from a CBCT. That's going to hurt. And it's not hurting because the patient's stressed and they're clenching their teeth, because that's what we've told them. We've told the patient that you're responsible for this because we assume that most of the problems were muscle-based. This is a joint-based problem without any doubt. If this was a knee, how would the discussion go with the orthopedic world? Markedly different than don't chew gum and go to yoga. Second thing is we look for increased risk of occlusal instability. Think of the disc as a three-dimension positioning tool for the condyle, a gasket. Normal disc position increases the likelihood of a repeatable path of closure. If the disc isn't there, we've got slop at the back end of the system. We've got slop at the front end of the system. Those are the patients that many times can't get their bite stabilized. And you're always chasing them either on the bite appliance, or unfortunately, sometimes we get into the game where you have to chase them on their natural teeth. Those are the patients I always want to keep in a splint because I don't like going back and adjusting teeth over and over and over again. So if I suspect these types of cases, I'm probably going to keep those in a splint where I can manage it. Again, take a look at this case. This is a really good example. You've got the disc sitting out in front of the condyle. The condyle is pushed back against the joint socket. Let's say you put an anterior deprogrammer in here. Any version, you pick the version of the anterior deprogrammer. What happens is it's going to decrease the muscle activity, but it also is going to increase the loading on the joint. And what you could see is that bone could move through the retrodiscal tissue there and start to change position in the joint socket. So again, I think before we start thinking about making appliances to try and stabilize joints, especially in the yellow-red cases, we want to look at the anatomy to know what we're dealing with. We talked about altered growth. Think of this as think of the disc as a growth center in other orthopedic joints. And if the disc is not covering the condyle in the growing ears, there's an increased risk of growth that's not complete either at the mandibular level or the maxillary level. If the disc isn't covering the condyle in the growing ears, increased risk for a class 2 occlusion, increased risk for a failure to achieve normal vertical dimension. They didn't degenerate their joints. They never got there. They simply never grew to normal. And a lot of times that now leads to compressed airways because their ramus lengths are too short for the mandible to project far enough out to keep a patent airway space. Take a look at the ramus lengths in this case, 51.49. That's at least a 10 millimeter loss, 5 millimeters loss on the left side. And now here's the airway compressed. You can see the compression of the airway space. You can see the anterior uncoupling of the anterior teeth. Same thing we've been talking about for years with joint-based defects. The increased risk for the class 2 occlusion now is simply manifested at the tooth level. And what you see a lot of times is treatment. I'm going to show you a case a little bit where the class 2 orthodontics is camouflaged by trying to move the teeth into a class 1 occlusion. We used to think that these cases typically came from genetic components. I think the reality is we know these are structural changes at the joint level. And basically the number of class 2 occlusions and structurally altered joints is underestimated in dentistry and in medicine. Here's what the bite looks like on that case, and all of a sudden this becomes an orthodontic nightmare now. Crossbite, open bite, irregular occlusal plane, all types of issues to work with. So if we can start to avoid these cases or recognize them, at least that we're treating them, we have a better chance. So those are the deep end of the pool cases. You know, the question is, how deep is the water? Is it a yellow or is it a red case? So how do these present in our practice? Something hurts. We assume that it's a pain-based issue. I'm going to tell you that the occlusal issues that we're going to see are almost always going to happen before pain. So the astute diagnostician will pick this up at the bite level before the patient starts to hurt. And again, typically it's a decreased vertical dimension. Either we grew to normal and lost it, or more likely we never grew to normal and never had it. Now, that can be soft tissue. It can be hard tissue as well. The greater the hard tissue deficit, the greater the malocclusion. How do we recognize this? We're going to do the history. Well, basically through the clinical exam. 6 things we do in the clinical exam, I've listed them there. I'm going to talk about the top 2 because those are the 2 most important in my mind. That's where I get most of the information in. Because basically, really what I'm trying to do is to figure out if we have to image or not. That's the whole purpose of the clinical exam, is to see if it's a green, yellow, or yellow, red case. Because if it's a yellow, red case, I have to be ready to talk about diagnostic records at the end of the clinical exam. What I used to say is, you've ever had an injury to your head or neck, and I got a lot of false negative histories because I wasn't asking enough questions. Now I take 4 histories: a joint history, a pain history, a treatment history, and a trauma history. First question, ever have clicking or popping? If they did, then we know they had structurally altered joints and ligaments torn. End of discussion, we know that. Is it popped or clicked in the past? If we have a previous click, then we know it's the 3rd video and it's either a Piper 3B or a Piper 4B, but we know it's probably more advanced if it's stopped. Does either jaw lock or have problems opening? I don't like locking jaws. For me, that increases the likelihood of a yellow-red. Is it locked in the past? Same thing. Jaws that lock generally have pretty significant structural alterations. I used to think it was muscle because that's what I was taught. I'm thinking now it's anatomy more from years of imaging and simply seeing it. So how old were you when you first noticed the problem? The answer I always am concerned when I hear is I've had it as long as I can remember, because I hear that a lot. The earlier in life the patient knew about the problem, the higher the risk, because it generally happened earlier in life. Treatment history. Have you ever had ortho treatment for a class 2 occlusion? They'll say an overbite. It really is an overjet problem. I'll ask if they had teeth extracted, because if they did, I'm starting to think the upper and lower jaws weren't growing. Headgear for sure is usually a sign of a class 2 joint-based case, because we're trying to restrict maxillary growth when the problem is the mandible isn't growing. Functional appliances move the jaw forward, thinking that the bone is going to fill in. It can happen, but I think it really would be nice if we knew if we were going to move that condyle forward or getting it back under the disc. Because if we do get it back under the disc when we move it forward, we have a much better chance than if we don't get it back under the disc. And if we don't get it back under the disc, we have the potential of maybe causing more problems based on what the anatomy looks like. So I think we need to be a little bit more careful when we start thinking about the appliances that are going to move the condyle relative to the condyle disc interface. Does the ortho take longer than 2 years? If yes, generally we're trying to move teeth into positions they probably shouldn't be moved. Ortho more than once, we've obviously got bite instability we're trying to chase at the tooth level. Same with multiple appliances, same with multiple bite adjustments. And if they've ever had orthognathic surgery, for me, that automatically puts them in the yellow-red category. Green, yellow, red. Is it a Piper 1 to 3B? Is it a Piper 4A to 4B? That's my thought process. Again, because I need to be ready to present for diagnostic records. We'll go to pain. Is pain higher than 5 on a scale of 1 to 10? Pain's a hard one because pain's different for everyone. Generally, what I'm thinking here is the higher the pain levels, the more likely there's structural alteration to the joint level. Sharper stabbing pain, same thought process. Pain early in life makes me think yellow-red. Headaches on a regular basis make me think that also. Trauma, I'm just going to go through a laundry list here. Have you ever been in a car accident? How old were you and how fast were the cars moving? Ever have a concussion? Ever have stitches in the head or neck? Ever have surgery with a breathing tube, which is basically a stretch injury? Ever have tonsils and adenoids moved? Another stretch injury. Wisdom teeth, another stretch injury. How many of your patients say my joint started clicking after my wisdom teeth were extracted? A lot. Did you participate in contact sports in growing years, think a compression injury or a whiplash injury? Multiple traumas, early falls on the face. So basically, when we go through the process, those are the questions I'm thinking of in my whole thought process. Am I green, yellow, red? If I'm yellow-red, I need to be able to present for diagnostic records. Let's look at the bite. The most common initial clinical presentation of structurally altered joints is a change in occlusion as opposed to pain. Now, typically it's a lack of anterior tooth contact, and what we're going to do is read the bite. 4 cases, let me show you in maximum intercuspation. Number 1, are the teeth uncoupled greater than the thickness of the disc in a fully seated position. Now, this is MI and they look pretty good. If yes, it's increased risk for a high-risk patient because we're thinking we lost the disc at the medial pole. Here's what they look like in a fully seated position. So these are uncoupled greater than the thickness of the disc. I'm going to say this is a likelihood that we may have an increased risk for a yellow-red case. When we start to image, all these cases are really tough cases. Worn bone, small bone, tough cases. So again, the bite shows you so much, but the first question is, are they uncoupled greater than the thickness of the disc in a seated position? Because if we just check them in MI, you just saw the bite can hide the defect. If we check them in a skeletal position, not CR, fully seated, because CR means there's a disc there. Quite frankly, we don't know if there's a disc there. In a lot of cases, there aren't. So that's why I generally don't say centric relation anymore. The term I use is a fully seated condylar position. What we know today, we used to think that if you had a bad bite, you have a bad joint. I think today what we know is that bad joints have bad bites. So let's take a look now. Question number 2, if the teeth been repositioned orthodontically, take a look at this case and you can see what's happened is the maxillary premolars are extracted. So move those teeth back in your mind's eye to where they should be. And now ask question number 1, are they uncoupled greater than the thickness of the disc? They are. This is the case that's camouflaged orthodontically. So it looks like a class 1, but it's really a class 2. And now when you take a look, what you can start to see is we don't have any room for a disc in the left side. And on the right side, what we've got is complete breakdown of the cortical plate. And you're starting to see heterotopic bone coming off the joint socket. Again, pretty unstable cases. Here's one more case. It's a camouflage orthodontic case. Look at the incisal edge positions. Third question is, are they in the correct position? Those aren't. Those are retroclined. Put those to where they should be, correct them, and now read the bite. That bite is uncoupled greater than the thickness of the disc. When we go back and take a look at where the bite should be, with the teeth in the correct position, again, we see structurally altered joints that didn't grow because they don't pass the 2/3 test. Those bones don't fill 2/3 of the joint socket. So we can be pretty sure that this patient had structural alterations of the joint before growth was completed. The question is, how do I seat the joints to look at that? You can use bimanual, you can use leaf gauge, you can use a deprogrammer, it doesn't matter. Really, all you're trying to look at is the anterior tooth relationship in a seated position. You're not necessarily looking at a seated condylar position that's repeatable because you may not be able to based upon the anatomy. Don't get hung up on the pinpoint of this. This is simply something that you can use to look in a skeletal position to take a look at things. We'll also look at the face, retrognathia, 14-year-old ortho patient. Again, if the mandible's not growing, go to the back end of the system. That's where the answers are. This is not genetics. This is early onset joint injury. This is not systemic arthritis. This is the first orthopedic joint that's injured in life. That's basically what it comes down to. Facial asymmetry, same thing. We can see the asymmetry to the left. We can see the lack of growth in the left condyle and joint socket as well. And when we start to look at the face, it becomes pretty apparent as well. So what's our tentative diagnosis based on occlusal facial analysis? Diagnosis based upon the exam. So here's kind of the cheat sheet that we look at from the exam. And the more things we have a checkbox by, the more likely we've got a yellow-red case. And that's really the way we're thinking about it. Everything that we're using this exam is being designed to see if it's a yellow or a red case. So how do we image the joints? What I'm going to do, I'm going to have Tom get involved here now, and let's talk about the Piper protocol. So here's the original prescription that Mark wrote. And what we've done is talked about where it highlight T1 tissues highlight fat, T2 issues are stir highlight fluid, and proton density has an improved contrast between the tissues. So Tom, why don't you talk about, I'll just click these slides, and why don't you talk about just walking down Mark's original protocol and then how you and I have changed it, okay?
Right. Well, first of all, I just want to say greetings. And Jim, that was an excellent summary of what goes on in the clinician's mind in determining when to image. You're obviously not going to image every patient that comes through. You're just going to image the high-risk patients. imaging is probably one of the things that you'll find in many of your practices. The hardest part is to find good imaging that will give you the answers that you need. And so that's something that maybe we can help you with through second opinions or through arrangements with some MRI centers that are in your area, because I know you're from all over the country and even all over the world. But anyway, the imaging process that we try to do is we always try to image in orthogonal planes, so we get a coronal and a sagittal view whenever possible. We will make those planes parallel and perpendicular to the wide axis of the condyle. So those are prescribed by the technologist based on out image. And then we do these different various sequences that will highlight fluids such as a joint effusion on a stir sequence or a T2 sequence with fat suppression. That'll give us a bright fluid in the joint when there's a joint effusion. It'll tell us when there's bone marrow edema, which might not show an abnormality, which usually doesn't show abnormality on a cone beam CT because you're not able to see bone marrow edema. All you can see is really the cortical bone and some little trabeculae in the bone. And then the proton density is kind of an intermediate sequence that we have found actually is the best way to see and outline the disc the disc margins and the posterior band. So we've kind of evolved to doing a stir sequence for the idea of seeing joint effusion, capsular edema, and bone marrow edema, and a T1 sequence, which helps us also see the anatomy a bit and also differentiate between edema and sclerosis in a bone. And that's something that we won't go into for you guys because you're not going to be really interpreting them until you get a whole series of them under your belt. And then the intermediate sequence is the one that we use to see the disc margins. So like I said, and the other important thing that many people image when they do send patients for imaging, they might image in a closed and open mouth position only. And the closed mouth position is usually in a kind of a gentle teeth clenching position or maximum intercuspation. And for reasons that Jim showed you, that can actually mask the pathology at the disc because the patient will sometimes protrude their jaw a little bit, and the condyle translates anteriorly in the socket. So it may tuck itself underneath the disc and look like a non-displaced disc. But at night, when the patient's lying in bed and trying to sleep, and the joint realizes it's not situated properly, the gasket isn't in position, that's when the grinding starts and the teeth wear and that. So what we like to get is a fully seated condylar position in the coronal and sagittal plane with the PDC, proton density. We like to get a maximum intercuspation, and then we like to get the incisal edge to edge. By the way the dentists do this here, we don't put those patients generally into those positions. The best way to do it, because our techs don't know how to put someone in a seated position or in an incisal edge position. They have to sometimes do that incisal edge to edge if a light guide breaks or something. But ideally, the patient presents to the dentist. You guys create the little plastic bite molds.
I'll show those in a second, Tom.
Okay. And then they switch them out as they're going through the sequences. And each one of these sequences takes about 2.5 minutes. So they are going to spend a fair amount of time on the table. And the more experience that the technologist gets, and especially coaching the patient, the faster we can get the exam done. And then finally, so the incisal edge to edge with the jaw protruded is very helpful because, as Jim will tell you, it allows the dentist to see that when they bring a condyle forward, that they're actually going to get it under in the proper position relative to the disc.
Generally, that class 1 canine is for a growing class 2 patient.
Yeah.
We'd be looking at if we can make a functional appliance. Can we move them forward and get underneath the disc? Now, that class 1 position could be variable, but the class 1 position is a general position that a lot of times a functional appliance will be built to. So that doesn't necessarily have to be where you're going to take that. You really want to take it where you're going to have the desired condylar position for the functional appliance.
And like Jim said earlier, the idea is to try to bring the condyles forward the minimal amount to get them into a good position relative to the disc, which there's generally laxity in those collateral ligaments that are attaching the disc to the condyle. And if they're less lax, you don't have to bring the condyle as far forward to get it under the disc. And then there's a translated position, which is the open mouth position. We do that to see, because sometimes the disc the mouth may have to be open to recapture the disc. So
the reason I made this chart is because when you go to your radiologist, you're going to have to explain to them what you're trying to learn from each of these sequences, because many times the radiologist is going to be using this protocol. So that's why I put this together. We can come back to this and maybe do another webinar on this, because this could be an entire webinar, quite frankly.
yes.
But this is really something that you can use to go back and talk to your radiologist. Says, I need each of these because this is what I'm learning.
Most radiologists, when they interpret TMJ imaging, there's a paucity of knowledge about what the dentist actually really needs to know. They haven't really been trained that well. They haven't, just talked to dentists and gone to the conferences that discuss this, but they're really not thinking in terms of disc on the medial pole or disc on the lateral pole. They're just trying to find the disc and then try to describe it in a way that kind of sounds like they know what they're talking about. They don't scrutinize the position of the disc and the condition of the condyle necessarily as you need it to be scrutinized.
Here's the bite records that Tom talked about. We'll use that same one for the CBCT, and we'll use it for our photographs too. My recommendation is take all your diagnostic records in one condylar position so you can cross-reference those. Could be MIP, could be whatever you wanted to do. My suggestion is to use a skeletal position, because as again, what we said before, teeth can hide the defect, the skeleton can't. So if we take everything from a skeletal position, it allows us, I think, to have a more accurate diagnosis in terms of the case. Let's talk a little bit about creating an imaging network. And Tom, I'm going to have you go through this in the next slide to kind of talk about how you do it when you get home.
This may be the most challenging thing for, I just saw a chat come up, and there's a radiologist who trained at the Piper Institute, just checked in on a chat. And that's excellent. I love that, because probably the most difficult challenge you're going to have is to try to get the attention of a radiologist and an imaging center or a hospital to try to learn what needs to be learned to give you a useful report, and take the time and have the technologists learn how to properly prescribe the sequences, to give you the best images possible. So I would say that most likely an outpatient imaging center where they're actually fighting for work, the hospitals are kind of fat and happy. The patient, they get the referrals. You're going to get on in a situation where you're on a telephone network trying to get through to a radiologist. And so I think if you can identify an imaging center, freestanding facility, ideally, that has at least a 1.5 T magnet, just 1.5 Tesla magnet, not one of the little open MRI low field magnets, but a good quality center, which you can look up in your local area on the internet, because they just look for high field or 1.5 T MRI scanners, outpatient, then try to contact somebody from like a manager from the center. If there's business to be gained in the outpatient imaging world, generally they're very amenable. Now, you're not going to immediately bring them 30 cases a month or anything, but it's a kind of a niche market that outpatient imaging centers would like to capture in an area. So it gives you a little bit of an edge, especially if you have a practice where there's more than, or an area where there's more than one dentist trying to do this. And trust me, from what we see in the Chicagoland area and some of the other places, there is no shortage of severe TMJ cases. Like I said, because the dentists in our local area are so good at screening the cases, I rarely see a normal TMJ come through. I rarely see a one or a two. They're all 3A, 3B or higher joints, and that is where you'll be growing a practice. I think it's a cutting edge area of dentistry that you guys can get in on early. I think if you could find a champion radiologist and maybe a lead technologist who's interested in doing this, that's the ideal thing.
So we've talked about 3 of our first 4 questions. Lastly, what are we going to learn if we do imaging? So MRI basics, it's commonly used for other orthopedic joints. It's the only orthopedic joint not routinely imaged. Basically, we've got T1 shows fat. First slide's normal. Second slide has a decreased fat content. The thought is fat's a pretty hardy cell to kill. If that fat is dying by what looks like a dark signal, that likely means the bone is breaking down as well. The way we verify that is by looking at fluid to see if there's any swelling in that dark area. So here's a normal fluid scan, and now here's a bright one that corresponds to the dark area that we saw. So what we're going to assume in this joint is that there is bone breakdown based upon what we see on the scan. And lastly, the disc is shown with a proton density. It's a nice picture to be able to see a disc pretty clearly. So that's why we've gone to those a little bit more. But that's really the basics.
I'll just add one thing. Now, in every other joint in the body, when we see a joint that has bone marrow edema or capsular swelling, the synovium is swollen and edematous, that is a sign of a higher likelihood of severe pain in that joint, because that is a bone that's damaged, in this case by a repetitive micro trauma, sometimes an individual trauma, twisting the knee or hyperextending the knee or an ankle or whatever. When we see bone marrow edema, that's a sign that someone is generally going to have pretty significant acute pain from that.
That corresponds to what we see in the literature as well, Tom.
That's a 5A type joint because that's an acute breakdown of the bone that we see there.
Yeah. So what are we going to learn? We're going to learn disposition. Is it 1 o'clock, 12 o'clock, 11 o'clock, or 10 o'clock? We'll look at the lateral and medial pole. We're also looking to see if that large 11 o'clock disc can restrict condylar movement or blood flow to the condyle. Basically, we want to see if the disc is occupying a space that the condyle would normally occupy. Now, we're going to image with multiple condylar positions to look at the disc. We'll look at fully seated, MIP, incisal edge, and translated. If you look at this case, this is kind of a thin, small disc, but it actually is in pretty good shape over the top of the bone.
Part of the reason why we like to do coronal views is because sometimes the discs, they don't just slide anterior to the condyle, they can slide directly medial or directly lateral or any combination. So we like to have a view, because I think that disc is probably a little bit more substantial, but it doesn't look like it because we're not seeing it in the plane. It's actually off the medial or lateral side of the condyle.
Basically, what we're looking to do if we're trying to figure out treatment position, we're going to choose the least forward position with medial pole coverage. So if we're covered and fully seated, we can build there. That's the ideal position for force distribution. If we're covered in MIP, build there. If we don't get covered till incisal edge, then you got a decision. And the likelihood is you're not going to build it incisal edge. So you're either going to live off the disc, or you're going to change the joint anatomy to either try and repair or replace the disc. Most of the time, we're going to live off the disc. Now, that's okay. I just want to know that so I can communicate those risk factors to the patient. So that's the thought process about treatment position from an image-based perspective. Now, here, this is a good example. This disc all the way across doesn't get on top of the bone. So we're going to either build off the disc or change the joint anatomy, one or the other. And again, most of the time we're building off the disc, but that does bring a different risk discussion to the patient. More likely for pain, more likely for bite changes over time. We'll do the best we can to manage it, Mrs. Jones. It just depends how the tissue holds up. That's the discussion. So, as Tom said, we can see discs come off laterally or medially. This is a medial displaced disc. That's why in coronals, you don't see it where the bone is. You don't see the disc. Coronals for me were hard when I first started because I wasn't used to that. Now I've read more of those over the years, so I'm used to looking at that disc. In fact, I looked at coronals first today to make sure I can kind of get an idea where things are from a front view. Second thing, what's the condition of the disc? Is it normal or is it decreased in size? Is it wedged in front of the bone so it prevents the bone from translating? What's the condylar position? Take a look at this condyle. That's in the back half of the joint socket pressing against the ear canal. What you're seeing now, I think we see a greater understanding that the fact that the condyle changes position when we have a displaced disc, and a lot of times that's pushed backwards. We call it an anteriorly displaced disc. We could just as easily call it a posterior displaced condyle. And what impact does that have on the lower anterior tooth position? Basically, it's a class 2 bite shift. It's anterior uncoupling unless the posterior teeth adapt through wear, intrusion, or a failure to erupt in the growing patient. We want to know what the condition of the bone is on the outside. Here we can see the cortical bone change. Now we're going to correlate that with CBCT imaging, but we're going to look at it on the MRI. What's the condition of the internal aspect of the bone? We've got edema in the marrow space here. Now we know that can be transient, but as Tom said, that's an increased risk factor for pain and bite instability. We changed vertical dimension at the joint level. Here you can see that the disc is forward. We're closer to the base of the skull. So is it increased, normal, or decreased? How does that impact the occlusion? Decreases cause a class 2 bite shift. We're going to look for swelling in the joint space because that correlates with pain. And then lastly, we're going to look at how much the bone can move. How much is that able to translate? Is the disc in the way? Generally, we want at least 30 millimeters of translation. Really, we want to get down to the crest of the eminence. So those are the 8 things that we're going to look at when we read an MRI. Now, I talked about putting together a template for this. We have templates that you can send to your radiologist that have these exact questions, and all they have to do is to fill that in. So let's talk about a few cases before we wrap it up for this evening. We talked about, because then we're going to have a little, Tom and I are going to have a little Q&A before we wrap it up. Structurally altered joints influence growth. Look at Eve, she's 12 years old. Bad discs, again, she's 12 years old. The bone didn't grow. It doesn't pass 2/3 of the joint socket level. This happens way earlier than we think in life.
Since the growth center in orthopedics, the growth plate in the long bones is something that is sacred. If that gets disrupted, you have short limbs or you have angled joint surfaces, all kinds of problems. That girl, 12 years old, who has most of the growth of the mandible is going to be occurring from the growth center at the end of the condyle, at the articular surface of the condyle. That jaw will stay the same size as her face and head grows, and she's going to be even more and more disproportionate the older she gets. By the time she's in her 20s, she's going to have a severely retrognathic face.
And then from an airway perspective, a lot of times you have to do the upper and lower jaw advancement. And the problem is now you're doing those on really compromised anatomy. Now, she ended up having a disc repair and has done really well with it. But structured joints can influence occlusion also. Take a look at this class 1 bite in maximum intercuspation and now in fully seated, quote, CR. Which joint do you suspect? Take a look at the bite. When you start to take a look at the bite, what you start to see, the bite shifts towards the shorter side. If the anterior teeth are uncoupled greater than the thickness of the disc, approximately 2 millimeters in a fully seated position, suspect that you've lost the gasket. Doesn't mean you have for sure, but this is a pretty reliable metric in my practice. Now, when we look at the imaging, again, really bad joints. When you start to take a look, compressed joint space on the right side, lack of bone growth on the left side. Has Tracy had the problem days, weeks, months, years, or decades? She's had this decades. She's had multiple bite appliances. Basically, you can't get centric relation with these joints because they're structurally altered. And that's why the prognosis is different. You know, we talk about centric relation because we talk about getting a superior condylar position. We should think about joint condition as well, because if we don't have a disc in place, it's not centric relation and it doesn't have the same prognosis then. Short ramus length, 54.1 on the right. Look at that, 44.6 on the left, 20 millimeters. The bone didn't break down, it simply never grew. You can see the joints were just crushed, nothing's left of them. It can influence pain as well, structurally altered joints. Susan's in a lot of pain as we look through here. Her chief concern is pain and function. Nothing's working well. Difficulty eat and talk. It's affecting her shoulders and neck. High pain levels. Problem's been present for years, but worse in the last 3 to 4. Another one who said she's been clicking as long as she can remember. Average 4, worst of 8 on each side. Early injury. Burning pain, which makes me think nerve pain. Sharp pain in the joint, which makes me think intercapsular pain. Multiple appliances. Here's some of our photography. But again, I wanted to show you this inferior view to read the bite. When you start to see a bite like that, you can see the pink bite record in the back that's indexing that in a fully seated joint position. If this is uncoupled greater than the disc, that's a really good metric, again, to think about taking a closer look at the imaging. Here's the screen captures that we put together from the jaw joints. I'm going to move to more magnified ones. If we look at the right joint, we can start to see again, fully seated, MIP, incisal edge, translated. On the right joint, we're a little bit anteriorly displaced in a fully seated and MIP. We're getting underneath the disc and incisal edge, and translated looks pretty good. Left is a totally different story. Disc is way out in front, long-term bone remodeling, long-term bone issues. So again, this is the disc that was probably injured first. So it starts to give us some ideas of what's happening. Short ramus length on the left side as well, 52.8 compared to 61.9. Another clear indication that, quite frankly, the left side never grew. So when we go back and say, has this problem been around for days, weeks, years, months, or decades? This is another decades case. Early joint cases, one after another, we've looked at tonight. Failure to achieve normal due to early disc displacements. That's what we're seeing today. Structurally altered joints can influence airway. These are the last cases we're going to look at tonight. These were all suspected 4s and 5s, but I wanted to really hit the airway because I know how much AACP looks at airway. So let's take a look first at Christine. Ugly joints with the cortical plate. Cortical plate breakdown on the left side pretty significantly. Short ramus lengths, not to normal development, and compressed pharyngeal airway space. That's case number 1. Paula, again, small. Look at that right condyle, 10 millimeters. That's half of what it should be. The left side is 60% of it would be. Look at her chin. Is it any surprise she's going to have a compressed pharyngeal airway space? Short ramus lengths, 53 and 54. We know we cannot diagnose breathing issues from cone beam. I don't want to in any way imply that we're doing that, but we are looking at anatomy. And I know that can change if she swallows. But what we start to see routinely is when we're not having a mandible that's projecting out far enough, quite simply, we've got limitations at the pharyngeal level that are pretty significant relative to the discussion about airway.
You have to also consider the fact that this is done in an upright view on a cone beam CT. What happens when the patient lies supine and the jaw relaxes backwards? The thickness of the base of the tongue, there's not a lot of room for that.
Exactly. When you take a look at John, you can see cortical plate bone loss on the left side too. For John's size, his ramus length should be in the high 60s, another loss of dimension, and another compressed airway space, one after another. Here's Sherry again. Look at the lack of mandibular projection, loss of disc space, cortical plate, not too good on the right side, short ramus length again, compressed airway again, uncoupling of the anterior teeth again. Same thing over and over. This is a really interesting case, Lee. Really retrognathic mandible. When you start to take a look at the numbers, 54, you start to get those small numbers. Here's what you see again, the anterior uncoupling, the compressed airway space. Now, the question is, okay, let's say that her definitive treatment for her breathing issues would be a double jaw advancement. How do you feel about doing it on those joints? That's why I think today, when you take a look at these, if you're occlusally based, you look at the mandible. If you're airway based, you look at the maxilla. The clinical reality, the deficit's in both. And I think we need to be more open to that conversation. I honestly think that the greater the tissue deficit from the hard tissue side, incomplete growth or inability to maintain, increased risk for compressed pharyngeal airway collapse. And ultimately, I think if we're going to treat airway today, I don't think you can get around understanding joints today, both from a soft tissue and a hard tissue perspective. That's why joint imaging needs to include both. Last case I want to look at was just with this study. Long face syndrome is thought to be primarily a genetic posterior growth pattern. Recent studies show it's a higher risk for having a disc disorder and altered morphology, decreased ramus and posterior face height. It's reasonable to postulate a developmental onset of degenerative joint disease could limit airway dimensions. And ultimately, the results indicate if there's been condylar growth disturbance somewhere in the growth cycle, just like we've been talking about over the last hour, there's a potential for change in the facial growth pattern to become more vertical and the airway to become more narrow, secondary to joint change. Closing comments clinically, change your thoughts on occlusion to include not how the teeth fit, but also how the joints fit. We can treat yellow-red cases if we understand the anatomy. You're treating them every day, so you might as well know the anatomy. These are the ones to be careful of. Class 2 occlusions, anterior open bites, worn teeth, overjets, cross bites, facial asymmetries, deep bites, gummy smiles, candid occlusal planes, airway cases, locking jaws, pain patients. How many of those are in your practice every day? There's a lot of this out there that we're not picking up on. Imaging with MRI and CBCT, don't fall into the trap that I can do it just with a CBCT. You can't. Now, I don't want to be so rigid when I say that. And if all you have is a CBCT and that's all you can do, I totally get that. But if you really, I think, want to understand it completely, we need both of those together. If you can't get the MRI, you do the best you can until you can get the MRI. But you have to understand you don't have the whole picture if you don't have both. So most people can get both. So that's why I'm encourage you to try and move that way in your practice. Your confidence when your treatment plan will increase dramatically because you understand joints and you understand occlusion at a higher level. Managerially, there are patients dying for these services in your community, and they're willing to work outside the insurance system. There are dentists who would love to be able to refer patients to you who would work outside the insurance system. If you're looking to build a practice, I'm going to tell you that without a doubt, this is the fastest way to build a practice and attract high quality new patients. They're not all crazies. Now, some of them have issues, but they're not all crazies because that's what we've been taught. Your case acceptance is going to increase because you understand it better and you're going to be able to communicate it better. Your profitability is going to increase, which is going to lead to decreased stress in the office and leave you more personal time to do other things besides dentistry. But ultimately, your stress level goes down, your enjoyment level goes up because you're more confident clinically and you're more successful managerially. But with that, I want to ask Tom a few questions here so we can do a little back and forth for a couple minutes. So, Tom, give the perspective of the radiologist about the timing in life for injuries at the joint level and the amount of structural alteration at early ages compared to other joints.
I see a whole lot of patients every month. They come through. I see a skewed population because they've been screened so well by the cadre of dentists that are in our area. Most of them are into the Piper McKee type of situation with knowing how to screen for them, looking for them. And I would say that something that really impresses me more than anything is the early age of onset of severe bone changes as a result of the injury to the joints that occur, in toddlers and young children, and the really severe hypoplasia, or we call it osteochondrosis of the condyles that occurs. And then what we see, usually females, but there's some males, but they come in with the pain and they have really pronounced internal derangements of their joints, more so than any other joint in the body, I would say. And it's just a very vulnerable joint. It's a complex joint. The motion of the disc and the attachments of the disc to the condyle, and the fact that it's not really well designed evolutionarily for mandibular growth because the condyle is so vulnerable to facial trauma. So I would just say that in too many words, but we see very severe joint problems in quite young patients.
What's the training that most radiologists will get, Tom, on joints?
Well, it's generally fairly inadequate just because, in most residency programs and neuroradiology musculoskeletal fellowship programs, there just isn't a lot of demand for, or there hasn't been traditionally a lot of demand for high quality imaging of the TMJ. So it's kind of a bit of a hot potato that people try to avoid really spending a lot of time reading TMJs just because they're not that comfortable. A lot of radiologists who haven't really had specific training in TMJ, which is the vast majority, really try to make a report that is somewhat wishy-washy and sounds like there's information there, but they're not giving you necessarily the information that you really need. So that's the one thing that I would say. There has to be some kind of desire on the part of a radiologist to do mostly postgraduate kind of training in this, with interacting with the dentist and finding out what they're looking for and learning about the clinical side.
The question is there a routine for a standing versus a supine MRI?
There's only one type of magnet that people use that's an upright magnet. The rest of them are all recumbent scanners. And the upright scanner is a fractional Tesla. It's not a 1.5 or 3T magnet. So you're not going to be doing very much imaging at all, if any, on an upright scanner. So those patients will be scanned in a recumbent supine position. But that's where the bite guides come into play. That you don't really depend on the positioning of the body to get the condyles in the proper position for the imaging. You have those bite registrations that are sent over by you, that are created by you.
What is your recommended reference atlas / image book for us to have on hand?
Mark Piper has a really good chapter in one of his books that's probably available on the internet, don't you think, Jim? Do you know the?
There is a chapter, Bob Kirstein wrote a book, and Mark Piper wrote an imaging chapter in that book. That is the best that I am aware of in print today. The nice thing is you can simply buy the chapter. It's like
Yes.
$37. So it's really a minimal investment.
I would say that, the chapter, you can buy it as a PDF,
Yeah.
and you can even give it as a housewarming gift to your local radiologist to do some homework, and it's excellent. I think it would be a really great thing for the radiologist to have for training purposes.
Totally agree.
This question is, I know this may be a loaded question, but can you speak at least briefly about a patient that has full dentition and a class 1 occlusion on side and a full step class 2 on the other side? Is this an asymmetrical growth issue, damaged condyle on a specific side?
I think that's a perfect question because that's a case we see very often. Here's my
Right.
thoughts on that. The class 1 occlusion and the class 2 occlusion on the opposite side. I always, when the question said damaged condyle, I try not to make that decision in my mind until I see the imaging. What I'm thinking is it's a structurally altered joint. It could just be soft tissue, could be hard tissue, but when I'm talking to the patient, that's one of the reasons why we're going to get imaging, Mrs. Jones, so we can help you make a good decision about what the treatment option is best for you.
I think that's such an excellent question because it basically makes the point that we're trying to make about imaging of the joints, because instead of having to guess why the occlusion is abnormal, you would see why the occlusion is abnormal. And also, the one thing that is you generally don't see a completely unilateral joint pathology. There's always some element of pathology. It may be a relatively minor manageable pathology in the contralateral joint. And it may even be that the joint less severe pathology is the more uncomfortable joint that the patient presents with. But that's just because the strain on the more normal joint, I think, is related to the altered chewing and grinding and whatever they're doing.
Excellent point, Tom. Totally agree. I was just going to bring up those points. That's exactly my experience as well. What you'll see on this case, when we talk about a damaged condyle, think in a bit more global view. There's a good chance you might have a shorter ramus length on this side too.
Right.
Does the US have dental radiologists as a specialty?
We do have dental radiologists as specialists. However, Tom and I have been working together so long that we've just continued to work together. Here's the problem, though. Most dental radiologists aren't looking at medial and lateral pole either. That's the problem. Really, most of the time, there's medial and lateral pole doesn't get a lot of discussion. And it's always been a puzzling topic to me, given the really clinical significance of the medial pole. Mark Piper was really the one who introduced this topic to me, but it makes perfect sense when you look at the joint anatomy. Because again, the medial pole being the load-bearing part of the joint, if that's the case, those are the cases now that, again, have a higher risk factor. So, because I know there's a couple of questions out here about information on courses. I have to tell you, I teach the advanced occlusion workshop at Spear, and we go over this material in detail for 3 days. But honestly, there's really a vacuum in this area now that Mark has slowed down and is retired. There's just not a lot of discussion about that. I started a Chicago Study Club program that is in Chicago that meets twice a year that does this also. But right now, those are the 2 places. But we need more people teaching it. There's no doubt about it, given the amount of people that are walking in with these types of problems in our office.
And the interesting thing, though, is that also I think the private practice dentists are somewhat leading the way on this, because the dental schools are not really embracing this quite yet. They're behind the curve a little bit.
Yeah. You're right. You're right.
What MRI diagnostic features for perforated disc, and what is the radiographic sequela?
Well, the perforated disc is basically the rupture of the ligamentous attachment. It can be a fragmented disc. You can have a disc that we see on MRI where you'll see a fragment of disc positioned anterior and posterior to the condyle. It's not real common. It's more common for a disc to tear at one of the attachments, one of the collateral ligamentous attachments, but we do see occasionally perforated discs right through the central disc rather than posterior band or medial or lateral ligament attachments. And the radiographic sequela of that would be an unprotected condyle. Those are the ones that will generally lead to wear and tear, which in an acute phase, it can be breakdown of the cortical plate that Jim was showing you on the CT. The MRI would show the bone marrow edema before the actual breakdown of the cortical plate. Osteochondritis dissecans can occur, just like in any other joint. It can occur where you have a little fragment of bone, osteochondral fragment that can crack off and create a little divot in the condyle. And then finally, in a more chronic situation, you can have a typical degenerated joint where you get subchondral reactive sclerosis and marginal osteophytes around the condyle, or flattening of the condylar surface and even the articular surface of the temporal eminence. And that those are what we call bone spurs in layman's terms, but we see those all the time in these more chronic sequelae of a perforated disc or detached disc.
You listed gummy smiles. Can you spend a moment further explaining the connection?
Sure. Gummy smiles, basically, if you think about it, what you've got is an over-eruption of the maxilla, especially the anterior, could be the whole maxilla. If that's the case, it's probably because the mandible wasn't out far enough to provide a holding contact. It's the easiest way to think about it. If those lower teeth aren't out far enough because there's a class 2 occlusion because of structural alterations at the joint level, the lower teeth have nothing to stop them, so they just simply keep erupting, and that results in the gummy smile. The other thing is retroclined anterior teeth. It's kind of the same discussion. A lot of times you'll see gummy smiles on retroclined anterior teeth. So ultimately, I think it's because the mandible didn't come out far enough, because it was a growth injury early in life because the disc came off the bone.
I just want to get back to one question about dental radiologists. There is a group, are they out of California? It's called Beam Readers.
Right.
They do the CBCT interpretations to help out. And one of the things that I would say is we have the ability to do second opinions. And also, if we happen to have a center that is part of the big group that we have around the country, the larger group, I should say, we could work with centers or do second opinion reads for you if you can. And there's ways to upload your patient's discs to a website. And we do a few of those. We're starting to get that. That's ramping up right now. But I would say if you do use one of the dental radiology services, one of the things you should do is present to them the whole idea of what you're looking for and let them know that, just a simple reading of a closed and open mouth view, or not telling them about the disc at the medial and lateral pole and all that kind of stuff. They need to know that that's what you're looking for. And then they probably would be willing to go ahead and answer your questions for your clinical issues.
I'm taught a majority of TMD symptoms are neuromuscular in nature. Only a small percent will have true disc dysfunction. What we were taught is that muscle was the primary source of pain. Muscle is absolutely a pain source in almost every case we treat. What I would add to that is the number of disc displacements that we were taught was really low. We underestimated the number of disc displacements, especially early in life. So while neuromuscular pain is there, there's also a higher percentage of disc displacements than we were taught. I'm going to tell you, in our practices, it's probably a third to a half. Now, they don't all need treatment, but the average orthodontic practice will tell you that 50 to 70% of their new patients are class 2. My belief system today is that class 2 patients have structurally altered joints. So it's not just my practice. Go to an average orthodontic practice, half their patients walking in the door have a higher percentage of having a joint-based issue. I've said today that orthodontics is one of the hardest things in dentistry because there's landmines everywhere. The class 1 patients are being done by general dentists using Invisalign or by patients using Smile Direct Club. But the orthodontic practice is really becoming the class 2 dumping ground. And as an orthodontist, it would be really nice to have a restorative dentist in your community you could send those cases to for evaluations. Everyone says, well, the orthodontist should image. I'm going to tell you, I don't think it's the orthodontist's job to work up the joints. I think it's the restorative dentist's job to work up the joints and then refer the patient to the orthodontist for the orthodontic corrections with a solid understanding of what the condition of the joint is. We've tried to push that off on orthodontists. I think that's our responsibility. I think we're the one that's going to be managing the case. Orthodontists only see the patient for 2 years. We've got them after that for who knows how long. So that needs to be our job to work up the occlusal workup before the orthodontic work is done.
Yeah, and I would say probably ideally the pediatric dentists are at the front line of this too, because they can basically have the opportunity to catch when the person comes in with the cracked incisors from a fall face plant or an elbow to the jaw or something, or the class 2 bites that they see. They can kind of pick up this stuff at a time when it's still maybe treatable and even preventable. That, you know, some of these changes that we see with the hypoplasia of the joint and the condyle, they can prevent that by early treatment.
Yeah, when you really think about it, the gatekeepers of this are the general dentists, the orthodontist, and the pediatric dentist.
You know, I would say probably even if you're not planning on building a practice around TMJ, the awareness of what's going on in the joint and the foundation is probably half the battle. And then you can actually then have the opportunity to refer someone who has a special interest in TMJ.
How long does a child have with a compromised TMJ before growth patterns are changed?
That's a good question. I don't know the answer to that. I think it probably depends if the disc comes off, how much the joint's being loaded. I think the more load that's on an unprotected joint probably accelerates that. But any thoughts on that, Tom?
Well, the only thing I would say is you really ideally, once puberty ends, your bones are not growing in length anymore. Your condyles, your long bones are not growing, they're done growing. So really ideally, sometime before the end of puberty, to give those bones a chance to develop is important.
Could you explain how disc instability affects growth of the maxilla, as you mentioned, when the other parts of the TMJ to the mandible is the temporal bone?
It's funny. I've really started to notice this more. Again, I have to credit Mark Piper for the one who really was the person who brought this to my attention, because I think the system grows as a unit because it functions as a unit. And if you've got a solid bite, class 1 bite, those teeth interdigitate, and I think they almost pull each other forward and the bone grows as a result of some of that interdigitation as things are growing. If they're not interdigitated, they don't have any force to move forward together. So that leads to one issue. But Carlos Flores-Merritt published this in 2007. It was really an article that one of the early articles that talked about maxillary issues related to TM joint issues, because we forget that basically the top surface of the disc is functioning against the base of the skull. And it plays a lot of similar roles as it does to the condyle in terms of maintaining bone and distributing load. So that has been now duplicated in animal studies, in human studies. So there's a lot more discussion about that in the literature than there used to be. And really, you can measure that on CBCTs. You can measure from the back of the joint socket to the maxillary first molar on one side, measured on the other side. And what you'll see on a pretty common basis is the side that has the short ramus length, that maxillary growth from back of the joint socket to mesial contact to first molar is shorter than the side that grows longer. So that, again, Mark Piper was the one that brought that to my attention. But once I started measuring on CBCTs and looking in literature, that's a pretty common finding now when you're starting to see, like I said, a lot more of that in the literature.
So if a joint issue is identified, there is a joint treatment while the patient is growing?
You've got 2 options. Well, you've got 3 options. 1, you can do nothing. 2, you can try and move the condyle under the disc, usually with a functional appliance. Or 3, you can try to move the disc back on top of the condyle with a disc repair. Those are basically your 3 options. If you do nothing, we have to understand that there's an increased likelihood that they're not going to grow all the way if it's complete herniation where it's off at the medial pole and lateral pole. Increased likelihood we'll have a compressed pharyngeal airway. So, on the other hand, everyone tells you not to operate on children. It's funny though, so 16-year-old tears their ACL, they get that fixed. This one, this joint gets ignored. Quite frankly, because we don't have specialty support. The real problem is the orthopedic world has turned a blind eye to this joint. There's no orthopedic support in the medical world, so it falls to the dental world, falls to the oral surgery world, and oral surgeons generally are busy taking out wisdom teeth and putting in implants. Most oral surgeons generally aren't interested in treating joints, and that's not in any disrespect to oral surgeons, because I don't do everything I could do either. I don't do endo because I don't like doing it. I understand if they don't like doing joints. I totally get that. Problem is, what it does, it puts the patient at a little bit of a disadvantage, because any other orthopedic joint, the goal would be to limit the amount of tissue damage as early in life as possible. This is the only joint we watch break down as it grows. That's the problem. And then when they're 25 and they need the double jaw surgery because they can't breathe, now what do you do on that joint that has a surface area of 80 millimeters and small pencil-like condyles? Those are the treatment planning questions today. So what do you do? Basically depends upon the imaging. If you take an MRI and you take it at a class 1 canine position where you might build a functional appliance, you're looking to see if you can move the bone under the disc. If you can, then you got a decision. You could either try to do a functional appliance where you move the condyle underneath there and try and get the maximum growth you can. That's going to depend upon if the condyle went straight forward or lateral or medial. The straighter forward it went, the easier it's going to be for the condyle to get back underneath there. Now, the other option in that case is you could repair the disc. Again, it sounds crazy, but for me, that's the only option that gets it back to normal. So if you've got the right patient, if you've got the right occlusion, if you've got the right surgeon, if you've got the right orthodontist, academically, that's a fabulous option because, as I said, it's the only one that gets you back to normal. Even if you do the functional appliance, you still got the disc off the bone when you're done with the functional appliance. So you've not really corrected the problem. What you've tried to do is to maximize the growth through recreating this condyle disc interface. Now, here's the harder case. If when you image, you can't get under the disc, now your options are limited. So now you're either going to do nothing, take your chances and see what happens, or you could do a disc replacement. Now, a disc replacement has advantages, but it doesn't have the advantage of disc repair because the disc won't grow as well if it's functioning against fat as opposed to a disc. Now, again, everyone's going to tell you not to do surgery, and I'm not advocating that you should, but if you're asking the options, those are the options. Now, you could put a bite appliance in those patients, but again, I guess you could put a bite appliance in if it's a muscular problem and it's trying to manage that, but you know, it all depends on what level you're talking about trying to solve the problem, and I guess really is the question.
Fabulous. Thank you both so much for your time. I know there's still some questions. I will work with Dr. McKee and Dr. Predey to get back to you on the questions that are still there. We're just quite a bit over, so I do feel that we should wrap it up. I did want to mention briefly, just because beam readers and the CBCT imaging came up, that Dr. Thomas Deal with beam readers will actually be presenting on CBCT and interpretation at AACP's pre-conference on August 10th. So you can check that out on our website, aacfp.org. Doctors, thank you again so much for your time. And this was just so much wonderful information, and we truly appreciate it.
Thank you.
It was our pleasure. Thanks for your attention, everybody. It was fun.
Tom, thanks as always. Appreciate it.
Thank you, Jim. Good job. All right. Well,
Thanks, everyone.
guess we'll sign off. Thank you.